All right, this being episode 2 of the Nothing Stronger show, and we're going to talk about low back and reversals, whether it's SI, whether it's QL, whether it's sciatica, which can dive in. So this month, as many people probably don't know, is National Athletic Trainers Month. So we're going to highlight our athletic trainer, even though this company's founded by 2 athletic trainers.
Yes.
But we have one of the best in the business here. I am his husband, but we're going to talk about everything, low back, and see if she wants to take it. So, first question, I think one of the most questions that we get is, what is sciatica? So, Jen, take it away.
Yeah. So sciatica is really, I think it's a very overdiagnosed type of pathology. And I think that a lot of people self-diagnose themselves with sciatica. And there's a whole variant of levels of pathology or some sort of injury to the sciatic nerve or to the structures surrounding the sciatic nerve. As it comes off your lumbar spine and as it goes into like your lumbopelvic area, into like your glutes and kind of behind your glutes, right? Your sciatic nerve will kind of come through down like kind of the meat of your butt, and it pierces through oftentimes what's called your piriformis, which is one of the muscles that comes from midline of it within your sacrum or your low, like below your lumbar spine, low back into your butt. And then it crosses kind of like a fan out to the side of the hip. And so sometimes if some of the back or the hip muscles, the back side of the hip muscles can get adaptively shortened or tight, or spastic or lengthened, really any sort of pathology to those structures, they can kind of sometimes chokehold the sciatic nerve. And that's when people will start to get some of that nerve type of pain, or desensitization or kind of lightning and electrical kind of pulses down through the back of the hip into to the back of the hamstring. Oftentimes it will stop right about the back of the knee. But I think the important thing to note is that it's not always an injury to the nerve, but oftentimes it's more of the structures coming in and around the sciatic nerve. And so when things don't have enough space to live and breathe, they tend to yell at you. And that's oftentimes that sciatica type of symptoms that people are feeling.
So, what does the treatment look like for sciatica?
That is a very loaded question. And the treatment for sciatica can really range depending on what the pathology is. Why oftentimes you see all these videos online of how to treat sciatica or how to treat SI joint or QL or whatever is going on. And it really depends on why. Most people live in kind of this anterior pelvic tilt position, right? And so the angle of their pelvis shortens up in the front and kind of lengthens out in the back. And oftentimes that will change those posterior structures of the backside of the hip structures. So oftentimes you need to fix those in the actual alignment of the pelvis in order to fix sciatica or sciatic-like symptoms. If you just treat the nerve pain or discomfort or desensitization of that nerve in and around the piriformis, you're often missing the larger picture of it, and you might not get a complete alleviation of symptoms for an extended period of time.
So does that depend on what modality you choose to treat based on what they're presenting as?
Yeah. So, I mean, you can use a variety of modalities. Oftentimes we use something called dry needling, to get into some of those posterior hip muscles, the posterior capsule of the hip. You could use shockwave, especially as it's starting to come down, like the peripheral nerve or as the nerve starts to come down and descend into the back of the thigh. And you could use the shockwave unit, in the mid, the low back region, as it's really starting to come out of its nerve root. You can use cup therapy, which is another modality where you decompress that area, and that just helps to improve some of the sliding capabilities of some of that tissue. It helps to restore some of the range of motion that might be lost. You can use exercise, you can use diaphragmatic breathing, you can use a whole bunch of exercises, really what is comfortable with the patient. And there's no one size fits all when you're treating sciatica or sciatic-like symptoms, but oftentimes it's the exercise that helps to change how the pelvis will lie.
So it sounds like it's a lot of it has to do with just the positioning of your body. So just curious from like a patient standpoint, things like nerve glides and things like that, is that just to alleviate pain? or is that going to be helpful in rehab?
Yeah, so neurodynamics and nerve gliding, nerve flossing is really the intention of it is to create space of those sliding capabilities of the nerve in and along the soft tissue that it kind of overcovers or that surround it. And so, oftentimes when you're doing this, the nerve flossing or the nerve gliding for the sciatic nerve, you'll focus a lot of like the hamstrings, a little bit of the glutes, and then obviously of the piriformis. And so those can certainly be helpful. Oftentimes too, it's like patient tolerance. Like what are they comfortable with? Because if you start adding in some of the more aggressive modalities or manual therapy techniques, they just might not psychologically or emotionally be ready for some of those treatment modalities. So that's going to play a huge piece into this as well. What are they able to tolerate? Are they willing to tolerate some things? And kind of what the patient's expectations of that play a significant role in it as well.
What are someone that has sciatica, or they think they have sciatica, what else could they be presenting as? What are the other injuries, pathologies that are maybe coming their way that they think they have?
Yeah, oftentimes I think if anybody has pain in their hip or their glute or anything like that, they just automatically think sciatic symptoms or sciatica. A lot of times there's pathology to the glute med, which is one of your gluteal muscles that allows for single leg stability when you're on one leg, and so that you don't get that hip drop on that side. A lot of times you get pathology or tendinopathy of that structure. And sometimes it's that posterior capsule of the hip just kind of in this spastic state and kind of pushing and driving that anterior capsule forward a little bit. So sometimes it's that piriformis. We see a lot of actually obturator internus, which is a muscle that feeds in with the piriformis and kind of that back capsule as it fans out in the back of the hip, but it actually is a really big significant contributor to your pelvic floor as well. And so sometimes if you're getting a little bit further down underneath the glute max and kind of into that pelvic floor, sometimes the obturator internus is a little bit of a culprit that people might confuse that with sciatic symptoms as well. Side joint pathology that tends to be in there, kind of clumped in as well.
What makes your sports medicine clinic different from the traditional insurance route?
What makes it different is I can do what I want to do without an insurance company telling me what I need to do. What gets really challenging in healthcare is that there have always been these standards of practice and standard ways to treat people. People don't fit into a one-size-fits-all approach. And so when you're working with an individual, you have to take that time to figure out why something is occurring and why this person might be presenting like this, right? If it's the SI joint and I just give them traditional SI joint injuries or sciatic injuries, right? What if their injury is actually coming from their arch or their calf or their shoulder blade area, right? So if you're not evaluating and taking the time to evaluate all of that, that can get really difficult to treat it appropriately, so that it doesn't become a longstanding or reoccurring injury. But unfortunately, in traditional healthcare with insurance-based models, if somebody comes to you with low back pain, you have to give them low back exercises, right? And so when you're doing those insurance claims, an insurance company might be dictating to a clinician, no, this person doesn't need this, or a cortisone injection or whatever, manual therapy, whatever the treatment or the standard of care has been for that injury traditionally, that doesn't always mean that that's what that person needs. And so here at NS, we really take that full hour to have that comprehensive evaluation to determine, okay, is it actually coming from somewhere else? And this is maybe just where the source or is the source of the pain actually up here in the generator, and where you're actually getting pain kind of sits further down the chain or up the chain or whatever it may be. But if you don't figure out that purpose, then you're never going to completely treat that functional line or segment or anything like that. And so I don't have to necessarily follow those quote unquote defined standards of care with that. And I can really take into account the patient objectives, their goals, what they're looking to get out of that treatment, what they're comfortable with, what I'm comfortable with, and adding my expertise into that.
Now, one more question, Jacob, and if you have any more questions, we can fire those away too. I've always been watching you for 15 years with the lumbar pelvic, lumbar fascia, low back. Why do you have this love affair with the low back?
Sorry, Tim, I can't hear you.
Can't hear me at all.
I heard, why do you have this love?
Can you hear me now?
Yeah.
Okay, so I've been watching you for 15 years with your evals and your treatment. Why do you love the low back?
Why do I love the low back that's a loaded question. Because it feeds one, I think because so many people, I love a challenge, right? And I love to figure out the why behind the why. And I try not to ever settle for what it looks like. Most people have low back pain at some point in their life. And it's not fair to just say, oh, you have generalized low back pain, or you have complex pain syndrome, or just these kind of like blanket terms. Well, that's not enough for me to sleep at night. So I love to do all of this digging. And the back really isn't as complicated as I think some people may make it seem. A lot of it lives in the fact that we just don't give our back a lot of love, right? We overuse it and we use it in poor functional positions. And so once as we're able to really change the relationship between how we live and how we stand, how we sit, how we breathe, and change that harmony between the pelvis and the diaphragm and the rib cage, I think it uncomplicates it a lot. And I love when I'm working with a patient and I start explaining all of these things and I start showing them pictures and they're like, oh my goodness, this makes sense, right? And so I think once as we're able to give a little bit of love and we're able to see how dynamic that whole structure is. And that's really what I appreciate about the back is it responds so well to doing the right things and changing that input. And so I think it's really unfair for a lot of people that have been diagnosed with these kind of blanket terms or just said like, hey, you're probably going to have back pain for the rest of your life. I think that's an unfair assessment. And so when you get to change people's lives and livelihood, and their ability to carry out activities of daily living or things that they love because they don't live in back pain anymore. I think that's one of the most rewarding kind of parts of being a clinician. And I think that's what just like fuels my love for the low back.
Interesting.
Any questions that you gave up?
No, I was gonna say, it sounds like it's very much like an not like an epicenter, but like an area where there's a lot of different types of injuries, and it's like what I'm curious about is what is it in our daily lives that we're doing that causes these things? Like, is it something the way we work or we drive or like what
we're doing right now, sitting on a computer?
Oh my God.
We have mastered, and everybody has their own way of doing it, right? But we've all mastered the way to complete a task, taking the path of least resistance, right? What way can we do it in order to minimize pain or discomfort or anything that we're feeling that feels? And so we sit in all these like weird positions, right? And we're constantly changing. We're forward, we're crooked onto the side. We weight bear on, predominantly onto our right side a lot of the times. We lean onto this left arm. We sit into this left hip. All of these things that from a postural perspective, from just like a straight up anatomical perspective, we tend to favor one side rotational wise, digital plane wise, frontal plane wise. We tend to favor one side versus the other. Unfortunately, that has kept us into this forward kind of position that puts a lot of our spinal segments into this terrible alignment, which is why we get all of these like reoccurring injuries coming into the shoulder, coming into the hip, coming into the, even into the foot complex, the knee, you name a joint. And I bet you 9 times out of 10, it will come back to your spinal segments, lumbopelvic hip, your diaphragm, your psoas. Most of the time it's coming back to one of those areas. But unfortunately, our everyday life in this westernized culture has really magnified or amplified the way that we sit and we operate, which is not conducive to feeling good when you're 80 years.
Awesome. That's great. That's a wrap. So I'll let you go because Jenn probably isn't eat all day. She has a client coming at 3 o'clock. So until next week, guys. Good job today.
All right.